Good afternoon, everyone. In today's webinar, we would be discussing about the characteristic and burden of the clot and the outcome of intravenous thrombolysis in acute ischemic stroke. Now, coming to the structure of stroke, structure of clot. Sorry. So the clot structure is very complex and it contains both cellular components and fibrin network. So cellular components are from platelets, red blood cells, white blood cells, and then we have a lot of fibrin networks, fibrous networks, and deranged DNA, mRNA pieces, and a lot of other things inside the clot. So the nature of clot characteristic will determine the outcome of the thrombolysis, or in a simple way, we can say that the softer the clot would be, it is easier to lyse, and the harder the clot would be, it would be difficult to lyse. So these clot characteristics are potential clinical markers when we want to know the target of therapeutic intervention, or we want to predict the prognosis, because once we are doing certain things, we just want to know whether how much is going to work or not. So coming to the characteristic of clot or characteristic of the thrombus, we can broadly divide it into two categories. One is RBC rich thrombus. So RBC rich thrombus contains a lot of RBCs. The fibrin meshwork is thin and filled by RBCs, and these clots are softer in nature. And then second kind of thrombus are platelet-rich thrombus, which contains dense fibrin network, platelets, von Willebrand factors, leukocytes, extracellular DNA, and these kind of materials. So these clots would be harder clots and they will be more difficult to lyse. So we can understand that it is a given. Now, this slide is just for an example. Today, what we are discussing is only arterial stroke, but just for example, it has been given that arterial thrombi are usually hard thrombi because they occur under high stress and they are platelet rich, where venous thrombosis thrombi are soft thrombi. But in this setting, we are discussing now only arterial thrombi, which can be hard and soft both. So this is the stroke thrombus composition graph. See, the stroke thrombus composition or a clot composition is not uniform hard or uniform soft. So every thrombus or every clot will contain areas which would be platelet rich and areas would be RBC rich. So some areas would be soft, some areas would be hard. So more the RBC rich areas you have, it is more likely that the composition will be softer and the results of IV thrombolysis would be better. So this is the definition of IVT responsiveness, that it is defined by any decrease in the clot burden, which is demonstrated by doing an angiogram after IVT thrombolysis. Usually angiograms are done after IVT thrombolysis when we are going for endovascular thrombolysis. So this study is in only a small fraction of patients, but this is how we determine the intravenous thrombolysis responsiveness by assessing the recanalization. So what is the thrombus permeability and IVT outcome? So thrombus permeability or thrombus perviousness is same as the perviousness of the soil, like how much seepiness the soil has in geology. Similarly, the thrombus perviousness is there, that how seepy the thrombus is, and it can be determined on non-contrast CT scan and CT angiogram. So it is not a theoretical thing. Radiologically also we can look at the clot and determine that whether it is hard or soft, and this thrombus perviousness measures will definitely associated with the outcome measures. A softer thrombus will have a favorable outcome, better MRS score, and better recanalization rate, better functional outcome. So how to determine it? So we should understand one thing, that if the clot is RBC rich, it will be more dense on CT scan. So of 1 HU, that is Hounsfield unit increase in the density of the clot means that there are 3.4% chances of increase in the chances or the odds of recanalization. So the denser thrombus, the more whiter the thrombus is, the odds for favorable outcome is higher. So it's can be assessed through non-contrast CT scan. The second important thing about the clot is the clot burden or the clot size. So not only the composition of the clot, but the burden of the clot or size of the clot also matters. So in this slide, the four variables are shown. The age and collateral circulations are other variables which we are not discussing in this session, but site of occlusion and amount and character of thromboembolic material is very important. Site of occlusion means if a large vessel is occluded, chances of intravascular thrombolysis being successful is less because the size of clot is bigger. And then amount of character of thromboembolic material also matters. So the more the clot burden and the harder the clot is, chances of success is less. And this we can see in this graph that it is not that MC artery occlusion. We can say that MC artery is occluded. But the length of MC artery occlusion also predicts the successful IPA treatment. Because if a small segment is involved, means the clot is smaller. If a long segment is involved, it means the thrombus or clot is bigger and chances of recanalization is less. So this is the importance of clot size. Now, how to calculate the clot burden? There is a 10-point clot burden score, where 10 is a fixed number, and then you subtract 1 or 2 points each for each area of absent clot contrast opacification. So you give 1 mark for infraclinoid ICA, supraclinoid ICA 2, proximal M12, distal M12, M21, and A11. And you reduce this from the 10. So because we are reducing it from the 10, the lesser the score is, more the clot burden is. So if I score of this 6 or more, it means the clot burden is less and recanalization rate and clinical outcome is better. So this is a clot burden score which can help us on angio to determine the clot burden and predict the prognosis. Now this slide shows the thrombus location and time. So what we are trying to convey here, that although the alteplase half-life is 6 to 7 minutes, it can be biologically active up to 6 hours. And sometimes our endogenous tissue plasminogen activator also helps in doing the lysis after the initial debulking effect. But for practical purposes, we are not waiting for 6 hours to assess the recanalization, because these days, if you have a facility for mechanical thrombectomy, patient doesn't improve clinically after intravascular thrombolysis, and there is a documented large vessel occlusion, we immediately subject the patient to mechanical thrombectomy. So this is largely of theoretical interest, that if you do angio 6 hours later, you may get a better recanalization if you do angio 1 hour later. For clinical purposes, if patient doesn't improve, we are proceeding for mechanical thrombectomy. So this is what is shown here, that the distal thrombus location, greater thrombus permeability, and longer time to recanalization assessment is more recanalization. So this density of thrombus I have already discussed in one slide, that clot is the primary target. So more dense the clot is in non-contrast CT, the more soft it is. So it is measured in Hounsfond unit on admission on non-contrast CT. And then we can take help of post-contrast CT and CT angiogram to assess the CP-ness or perviousness of the clot. And how we do it? We do study change in density of the thrombus after contrast administration. So a thrombus which is soft or which is pervious or which is CP will become more dense because the contrast has gone inside the thrombus. So this is, we assess void fraction for that. And then in angio also, similarly, we can assess the thrombus attenuation increase. So in angio also, we can demonstrate that the contrast has gone in. So the clot is permeable, pervious, soft, whatever we can say. So the contrast CT angio, plain CT helps us in determining the nature of the clot. And even on MRI, if susceptibility images, you are seeing a dense sign, dense MCA sign, it means the clot is soft and maybe consist of more RBCs than platelets. So this is density of thrombus, lower HU, higher proportion of platelet, higher HU, more RBCs. So this determining thrombus composition from radiological signs can help us in identifying patients which will result better from IV thrombolysis. Now in the end, what is the take-home message? See, the take-home message is that determining thrombus characteristics may help us. If we determine the composition of thrombus, location, size, burden, permeability, it can help us in predicting the prognosis. Right now, whatever the protocol is, we have not included the thrombus characteristics into those protocols. Whether the thrombus is hard, thrombus is soft, it is hyperdense, it is hypodense, the protocol doesn't change for IVT or doesn't change for MT right now. But probably understanding these characteristics better, these may be included in future protocols. Thank you so much for your patience.